Good morning, Melbourne. It is great to be here. I am over 60 now, and I have no reason to be here, other than the fact that I have a passion for teaching. I love Australia. My life has been imbued with friends throughout this country, especially in Melbourne and Sydney. So I come back to see my friends. I have the same passion for doing what I do that I had 20, 25 years ago, 30 years ago. Chris started with me at the very beginning. We've made a paradigm shift. As the world has changed, you know, you can go and hear didactic lectures online all day long. You don't need somebody to come in here and show you a bunch of slides anymore. But what is valuable is to have an interchange, a dialogue, to be challenged, to review, to not be afraid, to really challenge yourself as you look at cases. It doesn't mean you have to call out. It doesn't mean you have to be publicly embarrassed. But you have to be willing to put yourself out there, and that's true of anything. Tell your kids that. Do not be afraid to fail, because that is how you learn. When someone asks me a question that I don't know, that's an opportunity. I'm not afraid, even though I'm standing in front of 100 people. That's an opportunity for me to learn something I didn't know before. So you're going to learn from me, but I'm also going to learn from you. A lot of what we have created over the last 2 years is a lot different than what you have seen before. It's online. It's more along this format. It is very didactic. It is as if you were sitting next to me and we were reading a case and drawing with a pen the findings of critical importance, how to word them, how to describe them, what to say, what not to say, how to say it, what to avoid in terms of pinning the clinician in a corner. You know, when I first came here, the radiologist said, clinicians don't talk to radiologists here. I did mostly orthopedics in the beginning. And your country has evolved. I must admit, one of the good things about the United States was that the legal climate forced physicians to absolutely have dialogue from the very beginning. But now Australia has changed, and now there is more dialogue between the clinician and the imager, and there absolutely has to be in neuro and ortho. If there's not, you're just not going to be as good. A couple of other items before we start. I think everybody knows where the bathrooms are. They're to the right. I want to give a big shout out and thank you to my team for putting together what is a very complex setup. It's not easy to do, especially 6,000 miles from home. I would like to thank you all for making the effort to be here, and I want to thank my lovely wife who's dressed in blue out back, who doesn't have to be here. It's just the two of us, and many of you have seen our 6 children grow up. They are all grown up. 3 of them are radiologists or radiologists in training, and 3 are writers. One is the chief tweeter against Trump for the Democratic National Party. He works in Washington, D.C. He's the anti-Trump tweeter. He's very funny. Another one is a writer of books and a chef. And another one is a songwriter in New York who works for Arcade Records. So 3 are writers and 3 are doctors, in case you were wondering. And I am awfully proud of them. Now I'd like to take a quick survey. How many of you are actually neuroradiologists that do neuro as your primary function? Wow, okay. This will be, I think, very rewarding for you, I hope. How many of you do neuro as part of general radiology? How many of you are newer to neuro, been doing it less than a year, trying to get your skills up? Okay. All right, we're going to have a great time. This is packed with information. The comments, the dialogue, the commentary, and even I'm going to sprinkle a few slides in there, but there's going to be a lot of information. It's all going to be on MRI online if you want to go there. Otherwise, get your pen out, get your books out, and be prepared to write a lot. Also, in your bag, in your swag bag, are some very cool socks. They're MRI socks. I have my MRI socks on. They are anatomically correct, and you will win friends, influence people, and impress your spouse if you wear these socks to bed. They were the idea of my team and my brilliant wife. All right. Okay. Let's start out with this introduction to neuro, and we're going to focus on brain sequences. I'm going to go through this pretty quickly, and I'd like to start out with just a generalized approach to neuro. So one thing you're going to focus on is symmetry. The brain is almost symmetric, but there are going to be certain areas of the brain that you'll have to memorize that are not symmetric. For instance, the jugular vein. It can be 2 centimeters bigger on one side than the other, more commonly the right than the left. The petrous apices may be asymmetrically aerated. The remainder of the dural venous sinuses may not be absolutely symmetric. In fact, the paranasal sinuses may not be absolutely symmetric. And the anterior superior sagittal sinus gets smaller and hypoplastic as you move anteriorly. Those are just a few. But for the most part, fortunately, the brain is symmetric. You're going to look at the shape of the head. You're going to start out very basic. Is the head too big? Macrocephaly. Is the head too small? Microcephaly. This is more of a diagnosis of the clinician and measurement, but you can get a pretty good feel. And other cephalies, like plagicephaly, asymmetry, or turi or scaphocephaly, things we're going to discuss a little bit later on. But the take-home message is focus in on the overall brain size, shape, and symmetry. Simple, common sense stuff. I begin with the midline. Especially if you're looking at a younger individual, the midline cut is the critical cut, and it is the one that will show you most of the anomalies. We're going to teach you how to localize the brain by gyri and sulci and by key anatomic landmarks like Brodmann 44, which is the Broca area. You'll also have to do some of your own strong, persistent restudying to learn every single cranial nerve, even if you're doing neuro casually or doing it as part of a general practice, which is totally appropriate because neuro is such an important and common aspect of radiology. You'll have to learn the dural venous sinuses, especially the important ones and the ones that thrombose. You'll inspect them. You'll inspect every single major vascular flow void, carotids and vertebrobasilar. How long should this take you? 1 second. And repetition will be your best friend. There'll be images that focus on first-pass perfusion. No, an injection of gadolinium with a T1 weighted image is not a first-pass perfusion. It's an equilibrium phase form of contrast imaging, different than perfusion imaging, and you'll be able to do perfusion imaging with an injection and without an injection called arterial spin labeling. You'll be able to do diffusion imaging, looking at micromolecular movement of water in the brain and its restriction. You'll be able to measure cerebral blood flow and blood volume and mean transit time. You'll be able to look at the core of an infarction and the area around the infarction that is at risk, which is called the penumbra, all of which we're going to focus on in detail. But this is part of the routine assessment of a stroke patient, which has become so important because now we can treat and reverse the effects of stroke if we can get to that patient in less than 3 hours. Now, sometimes we'll go up to 6 hours, But 3 hours is the window. So if you have a loved one that has an acute neurologic compromise, you got to hurry. You got to rush and get that patient to the hospital. Because you're in the business of getting people better. There is no better business in the entire world. We're part of the most amazing club in the entire world. And that's how we're all connected. You're going to learn about the special sensory pathways. You'll learn all the cranial nerves, but you'll learn about the endocrine pathway, the taste pathway, the visual pathway, the auditory pathway, and I inspect every one of those, and it takes me less than 10 seconds. But repetition will be your friend. You'll look at the ventricular size for symmetry. Ventricles are commonly asymmetric. This doesn't bother me too much, but change bothers me if they get bigger or smaller. They can be too small, so-called slit ventricles in patients that are overshunted. You'll look at the ventricular pulsation. Too much, normal pressure hydrocephalus. Too little, obstructive, non-communicating hydrocephalus. Which ventricles are dilated? Which ones are small? Which ones are trapped? What is the overall shape, size, sulcation of the cortex? What's sagging? Well, at my age, everything is sagging. But in the brain, we're going to be interested in the optic chiasm and the cerebellar tonsils and a few other lesser structures that'll help us decide whether the intracranial pressure has been altered. And we'll look at the periventricular status and its white matter. When we're focusing on patients that have neurodegenerative disease, we're going to look at the shape and signal of the substantia nigra, the entorhinal cortex of the temporal lobe, the frontal lobes in Pick's disease, the entorhinal cortex in Alzheimer's disease, the extrapyramidal system in Huntington's chorea, the cerebellum and its peduncles in innumerable diseases and toxicities, one classic one being pontocerebellar atrophy or pontocerebellar degeneration. We'll look at the size of the hemispheres and the vermis. For some diseases, spare the posterior fossa, and some diseases spare the supratentorial space. Some diseases focus in on specific structures, as in progressive supranuclear palsy that involves the collicular plate. We'll look at the brain stem and the mammillary body, which might be affected in certain disease states, especially in patients with an acute alcoholic crisis where the mammillary bodies may bleed. Or you may see the hummingbird sign in certain degenerative diseases that I'm going to show you so that I don't tip off the diagnosis just yet. Or the big panda sign that you'll see in Wilson's disease. You're on call. You're an orthopedic radiologist. You're a body radiologist. You're an angiographer. But they say, you know what? You're taking call. And you're looking at a head from home or at the office. How do we protect the patient and each other? Here's how. We know the things that are dangerous. Okay, so, maybe we miss a small bright spot in the brain. Who cares? But here's what you can't miss. Acute hydrocephalus. Herniations, upward, downward, falcine, uncle, posterior fossa metastases. Is it bad if you miss a supratentorial metastases? It's not good, but it's not critically life-threatening. Patients don't die the next day from a supratentorial metastasis. They do die the next day from a posterior fossa metastasis. Dural venous sinus thrombosis in young pregnant women. You cannot miss that. They have to have heparin. You'll save and change a life. You can't miss acute strokes. You've got 3 hours to save that person's neurologic function. You cannot miss vascular dissections, which are treated acutely or subacutely with heparin or its derivatives. You should not miss aneurysms. especially ones that are bleeding. You cannot miss a bleeding aneurysm on MR or CT. You cannot miss fractures simply because it's a medical legal issue, and sometimes it is a medical issue. And you can never miss spinal block with loss of the cerebrospinal fluid on an MR in the sagittal and axial projection in a patient with myelopathy. Now, this is a neuro course that's functioning on, that's focusing on MR, but I need to show you some critical CT signs. For instance, here's a patient with an intracranial hemorrhage. But what's that? That is actually blood leaking out from the vessel, actively creating that hemorrhage. This patient's going to die unless something is done immediately. That is known as the spot sign. So again, these are on-call pearls that will help you avert a catastrophe. Another one that you have to scroll up and down on to see a little bit more easily is the swirl sign, where you can actually see from image to image the signal intensity and shape of high attenuation blood, Hounsfield units 70 or 80, swirling about and changing shape, known as the swirl sign. Now I'm going to go through some sequences pretty briefly. Let's start out with this one. This is the old proton density sequence, long TR, short TE. We don't use it anymore. We've replaced it with a flare. It shows some of the major white matter tracks, which I'm not going to talk about right now. But this, along with its offshoot, the flare, show 90 to 95% of all pathology in the brain. Therefore, you cannot do an MR of the brain without one of these related sequences. The T2 weighted image is a refining sequence, not a detection sequence. It'll help you characterize abnormalities. It also does a good job of showing the distinction between gray and white matter, and sometimes it can be a supplementary tool in assessing the amount of sulcation present in a younger patient. Some newer sequences include variants of gradient echo. Now, a gradient echo differs from the two basic spin echoes I showed you in that they are very prone or susceptible to shifts in the magnetic field. Therefore, they're very prone or susceptible to things that change the magnetic field, like metal and iron and hemosiderin and blood and titanium and steel and clips, which makes them both good and bad. But when you're searching for little areas of siderosis, they can be valuable. Because these are very robust sequences, you can do very, very thin slices with three-dimensional imaging. Some of you know these by the name of Bravo, MP Rage, and 3D T1 fast field echo. And what these represent, including this one, the 3D spoiled gradient echo inversion recovery image, are the names given to these by various vendors. Don't memorize them. They're here simply as a reference for you. So for instance, this would be Siemens, this would be Philips, this would be GE, and I think Bravo may be Hitachi. I'm not sure on that one. So you can perform these types of sequences in 3D. 3D means very, very thin slices. So here's a 1 millimeter cut on the right. It looks T1 weighted, right? White matters white, gray matters gray. Here's a standard 2D T1 spin echo. Why might you use this? You want very, very thin slices to look for a 0.5 millimeter sized melanoma metastasis. That might be a reason. Let's skip over this one. This is called a gradient echo variant in which you combine gradient echo with spin echo. One of the names given to it is called GRACE. It used to be used historically to introduce both spin echo anatomic information and gradient echo susceptibility information to see iron and hemosiderin and blood all on the same image. we don't use it as much anymore, so I'm going to partially ignore it. This is a fabulous set of sequences. However, those of you that are staying for ortho, if I gave it a rating for how valuable it is, for neuro, I give it a 5 out of 10. For ortho, I give it a 10 out of 10. So if you're coming back for ortho, do pay attention to the additive gradient echo sequence, which is a gradient echo that is water-weighted, powerful, high signal, therefore thin sections, with fantastic visualization of anything that contains calcium, blood, iron, hemosiderin, etc. Some of the names given to this are Adage, Hitachi, Merge, Philips, Medic, Siemens, and Merge is GE. I apologize. Hitachi, GE, Siemens, and Philips. Here's what it looks like. This is an axial Adage. It is a reconstruction of a 0.8 millimeter series of sagittals reconstructed in the axial. There is now coming of age MRI of the spine in 5 minutes. That's right, 5-minute acquisition. And you reconstruct the rest. And it works. As long as you are an expert or master level reader, which is our goal, to get you to that level. These additive gradient echo sequences are very fluid weighted. So the CSF is going to be bright and the cord is going to be gray. Another sequence that you're probably not familiar with is the T1 flare, which means there has to be a T2 flare. The T2 flare is the one you use that is the heart and soul of every brain MRI. It's the one that shows all the MS plaques. It does a good job of showing subarachnoid blood and some other pathology. The T1 flare can be used as a supplement to the T1 when looking for metastatic disease. It also has very exquisite contrast resolution between white and gray matter, and therefore may be helpful in assessing myelination in children. The T1 flare can also be combined with movement suppression sequences, which I have down here. And the reason I put them in here is when you use a movement suppression sequence, let's say you have a Parkinson's patient that's wiggling their head, and you turn on the movement suppression sequence called radial, blade, propeller, you decrease the overall contrast resolution of the image. But you see, the whites are whiter and the darks are darker on the T1 flare than compare with the T1 spin echo. So it is sometimes used for assessment of the relationship of white matter and gray matter. So here are some heart and soul sequences of MRI. That's a reconstruction of a very thin section, three-dimensional T2 flare. Now you might say, it's a T2. Why is the cerebrospinal fluid dark? Because flare stands for fluid attenuated, fluid suppressed, inversion recovery. So even though it's T2 weighted, the water is knocked down. And the only water that you're going to see is water that is intermingled or commingled with more solid tissue, like these white matter lesions of multiple sclerosis. The white matter lesions are far less conspicuous on the T2 spin echo than they are on the flare. Flare can be performed with two-dimensional imaging or three-dimensional imaging. The blessing of three-dimensional imaging is that it's extremely thin, so if you want to see it sagittally, you reconstruct it. And I'm going to show you on the Intella image how to go sagittal, axial, coronal at the click of a button, how to go curved, and how to go oblique. That's a little more advanced, and we'll do that a little bit later. But the plaques are more obvious on flare than they are on the T2. Diffusion tensor imaging. Well, let's talk about diffusion imaging. What's diffusion imaging? Diffusion imaging is when you look at the change in the micromolecular movement of water. Water and fat, they're just not friends. Kind of like in our country, the Democrats and the Republicans are just not friends. So they repel each other. The only difference is that in diffusion imaging, the fat and the water don't use bad language, and the Democrats and the Republicans use bad language. And I can see that you have a very low threshold for your sense of humor. Actually, it's a very high threshold. So the humor is out the door. I'm going to throw it out. I'm surprised, though, because Aussies have the best sense of humor probably on the planet. So we are looking at fat repelling water in a direction. So if you have big, long white matter tracts, they push the water along those white matter tracts. And because of that motion, we're able to identify specific larger white matter tracts in the brain, and we're also able to measure the speed of micromolecular movement. And that translates into a pixel. And so that pixel may actually demonstrate the velocity of that movement. So you'll have a picture that shows the actual water being restricted, and then you'll have a picture that actually maps out the velocity of that restriction. And I'm going to show that to you in a few moments. Now, if you can do all that, you can make a picture of all the white matter tracts in the brain that are repelling water in all different directions, front to back, top to bottom, side to side, obliquely. And these are called eigenvectors. So these vectors will allow you to see all of these tracks, and if you want to, by direction or by velocity, you can give them a color, and you can make maps of the white matter. That's what diffusion tensor imaging is. Now here's diffusion imaging. Now when you do diffusion imaging, you can dial up the volume. In other words, you can make it more sensitive to diffusion or less sensitive. Now normally what happens is the water is moving at very, very slow speeds along the big white matter tracts because it's being repelled. But what happens if you kill a cell? The cell membrane is injured, the water goes in, the water gets trapped, the water cannot move. Diffusion imaging detects that within 3 hours. In fact, it detects it within somewhere between 6 minutes and an hour. So very early on, the diffusion image can define cell destruction in the brain and define the core of an infarct. That's critical. That is part of the heart and soul of stroke imaging. So here's a normal one, a normal diffusion image. We can then take that volume and dial it up to make it even more sensitive to alterations in movement or restrictions of movement as the cells have died. And that's called the B value. Turn up the B value, you will see loss of micromolecular motion more sensitively. This is a picture of all those white matter tracts in all those directions we talked about. And if we want to, later on, we can turn them into colors, and we might want to do that for certain subtle reasons. We can then take every single pixel and assign it a velocity of water movement. And that is known as a parametric ADC map. These are all very important in the assessment of patients who have had brain damage from hypoxemia or stroke. I'll run through tractography very quickly. This is simply the colorization of those tracks. I'm going to skip over these slides for now, but just illustrating how sophisticated you can get, showing tracks like the corona radiata or the longitudinal fasciculi from front to back by analyzing the speed or velocity of flow and their direction. Here's one that is seen in the axial projection that will be a beautiful comparison to a case I'll show you later in a patient who has had a concussive injury from playing contact sport. The only abnormality in this young man was his tractography image. So this is your tractogram image, and here you see some additional imaging showing the arborization of the corona radiata into the centrum semio-valley going up into the brain. Diffusion kurtosis. Not going to say a lot about this. Again, all of these slides and explanations will be on MRI Online. But what kurtosis is it's an analysis of the heterogeneity of diffusion in an object or a piece of anatomy. So if you're in the subcortical U fibers, they should all look the same. But if you're in a glioblastoma multiforme with necrosis and solid tissue and semi-solid tissue, that's all going to affect the character and the velocity of the diffusion. And so what you're going to see is heterogeneity of the diffusion within that object. That is one of the basic principles of kurtosis, which works the same way as diffusion imaging, except you have to use a few extra gradients. Kurtosis is not a part of routine MRI of the brain. Blood-sensitive imaging, this one is. You should not be doing brain imaging without a blood-sensitive sequence. If you have an older scanner, gradient echo imaging, water-weighted, will serve as your blood-sensitive sequence. On a scale of 1 to 10, I'd give it a 6. This is a 10. It's a form of echoplanar type of imaging using gradient echo technique. So it's sort of like a turbocharged gradient echo. Some of the names given to it are SWAN, SWI, Venus Bold, and it finds blood, iron, and calcium as good or better than any pathologist. Here you've got a blood-sensitive sequence that's normal, but look at the iron deposition that's seen in the medial aspect of the corpus striatum, an excellent way to evaluate the presence of iron or lack thereof in Parkinson's disease. Compare it with the T2 weighted image and the T2 flare, and now you have the guts, the heart and soul of morphologic and contrast imaging on MRI. There's an axial T2 weighted image, a moderately water-sensitive sequence, and then we apply our blood-sensitive sequence, and we see our lesion looks like popcorn with some dark areas and just a little blush of high signal intensity gliosis around it, the typical appearance of a cavernoma of the brain. Here's an example of a more sophisticated application of blood-sensitive imaging, BSI, SWI, SWAN, or Venus Bold. I'm repeating them for a reason, because you're going to use them. So here we've got an axial image demonstrating the iron in the substantia nigra. Unfortunately, Parkinson's disease has probably hit pretty close to many of us in this room because it's a common disease, especially seen in patients over the age of 60, and it's a very difficult disease to manage. So we see the more medialized appearance of brain iron in the midbrain, and then magnified, we see how the iron is starting to bleed into, from the substantia nigra, into the red nucleus. Normally, there'd be a crisp area of separation here. That is one of the cardinal signs of Parkinson's disease, along with a wispy loss of iron along the lateral aspect of the cerebral peduncle, known as the swallowtail sign of Parkinson's disease. Unfortunately, in this case, we've got a patient that has Parkinson's disease that has taken that iron and accumulated it in a place where it shouldn't be. We've got a tremendous amount of iron that is now deposited in the putamen. But look how difficult it is to appreciate it on the T2-weighted image. Look how easy it is to appreciate the abnormal accumulation of iron in Parkinson's disease on our blood-sensitive sequence. And this is showing you a patient who has a different problem, Parkinson's disease, where at 1 year, the brain iron, which should normally be present to some degree, not as much as in the last slide, but to some degree, the brain iron has started to dissipate from the putamen in the Parkinson's patients at 1 year. Phase-sensitive imaging. This is another type of white gray matter imaging that is used in pediatrics. I put it up here just so you're familiar with it, and you can go to MRI online to learn more about it. But it is another sequence along with gradient echo inversion recovery and T1 flare that can be used to look at the degree of sulcation and gyrus formation in the pediatric population. And you can put surface coils over this superficial aspect of the scalp or brain to see whether you have pachygyria or polymicrogyria. You can also perform these phase-sensitive sequences by inverting the pulses multiple times. And the reason to do this is to enhance your ability to look at plaques, demyelinating plaques in the brain, which show up a lot more avidly when you perform these phase-sensitive inversion recovery sequences. And all I want you to remember about them right now is phase imaging can be used for white matter assessment in subtle cases. It's especially valuable when you want to quantify and qualify the plaque burden in a patient who is being treated for multiple sclerosis. Now here's a more mainstream sequence. It's called MR cisternography. In the past, we might have injected a patient using lumbar puncture to put some contrast material or agent that is radio emitting and do a nuclear medicine scan to look for a leak, the so-called nuclear cisternogram. We don't do those anymore. They're not that effective. The sensitivity and specificity is not excellent, and it's not very good for the environment. What we do now is we do ultra-thin sections throughout the entire brain, sometimes the entire spine, looking for a small hole or leak with the most water-sensitive images that we have. And what are the most water-sensitive images? 3D, heavily T2-weighted images, or 3D, heavily water-weighted gradient echo images like the adage, the merge, the medic, the MFFE. Perhaps the best projection in the brain, we'll talk about the spine later on, is the coronal, because many of the leaks occur at the skull base or through the sinuses or through packing where there's been surgery. So you start in the front and you end in the back with very thin slices that are overlapped, and then you can reconstruct sagittally, obliquely, in any projection you so desire. You can also use cisternography with these very heavily water-weighted sequences, and I have a few others listed for you here, to look at the cranial nerves. You don't need to give contrast to look for an acoustic schwannoma anymore. You can see the lump or bump on the superior vestibular nerve very nicely using this technique. Here's one on the right. You don't need contrast to visualize that schwannoma of the superior vestibular nerve. So the take-home message is, give contrast if you want, but if you really want to see the skull base and posterior fossa with water emphasis, use one of these heavily water-weighted sequences with ultra-thin sections with 50% overlap, and the family of sequences include heavily weighted T2, fast spin echo, all 3D, The other family is the additive gradient echo shown here. Another family that I haven't mentioned yet is called steady state free precession. One example of that would be, if you're GE users, Fiesta. So those are the three that you should be thinking about. Heavily weighted spin echo, heavily water weighted newer additive gradient echo, steady state free precession for MR cysternography of the brain. Bye-bye nuclear scintigraphy for leak. First pass, perfusion. This we use in stroke patients. Another place to use first pass perfusion is when you're trying to assess the type of malignancy or the aggressiveness of a malignant lesion. For equilibrium phase injection is meaningless, or it's of limited value in determining the aggressiveness of a brain tumor. But first pass imaging showing inordinate hypervascularity is excellent. We're going to share with each other and teach you how to use the perfusion data. We're going to look at things like the cerebral blood volume, the cerebral blood flow, and the transit time through the brain, which is one of the most sensitive markers for compromise in flow to a segment of the brain or a hemisphere. In other words, it's one of the most sensitive methods for looking for stenosis of a vessel downstream. A formula you'll need to memorize, especially if you're in training, is mean transit time equals cerebral blood flow divided by cerebral blood volume. Diffusion imaging. I alluded to this earlier on. It is a way of looking for the lack of micromolecular movement of water in the brain. The water gets stuck. Now, the water can get stuck in the cell. If you got a lot of cells cramped together, like in lymphoma, the water can get stuck between the cells. So lymphoma would be another cause of diffusion restriction. Anything that limits the movement of water is going to give you an abnormal diffusion image. And on the diffusion image, that shows up as white. But because the velocity is low, it shows up on the parametric ADC map as low. Now, you'll be able to use the diffusion image to make tractograms and kurtosis maps and things that we've already briefly touched on. We'll also be able to vary the B-value, the sensitivity with which we pick up diffusion abnormalities. The higher the B-value, the greater the sensitivity. The higher the B-value, the uglier the image. Now, in some parts of the body, you need certain baseline B-values. For instance, prostate cancer. You need a B-value of 1,400 to detect prostate cancer consistently. In the brain, a B-value of 800 will do. But I like to see about 1,200. But 800 will get you there. Let's talk about the causes of diffusion restriction. If you were a little asleep, you woke up late, this is the moment to wake up right now. Let's talk about what causes diffusion restriction. Breakdown of the sodium-potassium ATPase pump, cell wall damage. This happens with ischemia, but if you have no nutrients, it happens with hypoglycemia, and it happens with protracted seizures. Dense cell packing, lymphoma, small cell lung cancer, squamous cell carcinoma. Tissue vacuolization, Creutzfeldt-Jakob disease, slow-acting viral infection. Heroin abuse, which is a huge problem in the United States right now. Demyelination with necrosis. And DAI, diffuse axonal injury. High protein viscosity. Right? Things aren't going to move as readily if they're very thick, like an abscess or an epidermoid, or extracellular blood in the form of deoxyhemoglobin or methemoglobin. So here's an example of a T2 weighted image with a flare. This is water-suppressed imaging, but T2 weighted. We said the signal will go up when you mix water with proteinaceous and or solid or semi-solid tissues. The entire parafalcine region is high, but how old is it? Well, the diffusion image tells you the area in the front is older, the area in the back is newer. Now we're going to learn some tricks and pitfalls in using diffusion imaging as it relates to time, because there will be a period of time when the diffusion image will normalize and produce some confusion for you. But let's not go there just yet. So we're showing you how we might use diffusion imaging in picking out a new infarction on top of an old infarction, which is a candidate for potential thrombolysis if we catch them in the first 3 to 5 hours. Typically, you can catch them within a matter of minutes to an hour with diffusion imaging, and that's why you want to do diffusion imaging to assess the core. We'll talk about stroke imaging when we get into the vascular section. For the first thing you're going to do in a stroke, CT. In the ER, CT first. Once you establish what you're dealing with, then you run to the MR scanner to make some decisions or not. But that's a story for another discussion. Arterial spin labeling. It's just a fancy form of perfusion imaging. All you do is you alter the spins of blood that are coming into the brain, and then you measure how fast those spins, which have different spins than the ones that are already in the brain. So let me see if I have my pointers here. I do. Thank you, Alex. So let's say I've got some spins up here in the brain, and I have some spins down here in the carotid. And I excite the spins in the carotid. Well, they're different than the spins in the brain, right? Because the spins in the brain, they didn't get any excitation. So now the ones that enter the brain look different, and we can identify them and follow them in and out of the brain and see their velocity. That's all arterial spin labeling is, but we didn't have to inject anything. So that will also be a story for another day when we talk about vascularity. But here's what it looks like. No contrast injected. This is simply tracking the velocity of spins. Yes, there are no spins in the ventricle because it's made out of water. But we're seeing where the perfused spins enter the brain and the flow is faster and more avid in the back of the brain in a normal individual. In a young, healthy boy, they're going to have more blood flow. That's why you're so much smarter when you're younger. And then we see some physiologic spin tags in the brain, in the frontal lobe when the person is performing a task, or in the back of the brain when the patient is performing a visual task where there's increased blood flow. And we see alteration and a patchy pattern of the spins in the right side of the brain on the diffusion image with the spin label in a patient who has had a vascular compromise. Permeability imaging. Let's talk about basic permeability imaging. When you inject gadolinium and you do a T1 weighted image, you are looking at the equilibrium phase, extravasation of contrast out of the vessel, transgressing the blood-brain barrier. If the blood-brain barrier is intact, nothing happens. That is different than dynamic contrast enhanced MRI, DCE MRI. In DCE MRI, we are looking at the exchange of blood admixed with gadolinium, because gadolinium is kind of attached to it, between the intravascular space and the extracellular fluid space, which should be pretty even. But what happens if it's not even? Then you might have increased appearance of an object. Or what happens if it goes into the vessel too fast? It goes in the vessel, it comes out of the vessel, but it goes into the vessel faster than it's coming out. Then you get what's called a washout. And you're all familiar with that from breast imaging, but that happens with a lot of tumors. They may be hyperperfused, so you get immediate leakage from damaged dysplastic endothelia, and then you get reentrance into the capillaries, taking it away faster than it's coming in. Or maybe it comes in, but it goes out very slowly, so you start to get an accumulation. You get a wash in. That's DCE MRI, which has little to do with the 3 to 5 minute standard T1 spin echo image, which is telling you about the status of the blood-brain barrier, which, by the way, is not competent in every structure, right? Pituitary doesn't have a blood-brain barrier. The meninges don't. The area postrema doesn't. The pineal gland doesn't. And that's why they enhance on a normal MRI of the brain. So 2 separate things we're going to be talking about. The exchange between compartments, the blood compartment and the ECF compartment, and the blood-brain barrier. Notice that I did not talk about the cell. The cell is excluded from these compartments in DCE MRI. There's nothing going into the cell unless there's a problem. And that will be a story for later on. So this slide, which you can find in MRI online, articulates exactly what we just said. 2 compartments, the blood compartment, the plasma compartment, and the extracellular fluid space compartment. So when we are looking at a stroke patient, how many of you work in a hospital? Quite a few of you. So this is relevant to your everyday practice, especially if you're on call. You're going to have a flare image, a perfusion image, a diffusion image. You'll have probably a T2 and a T1 if you have time. If you don't have time, they may eliminate those. If you have time, they might do an MRA of the brain and the neck to see if they have to do neck surgery at the time that perhaps they do thrombolysis, or maybe right before it or after it. And this will all be done with some specialized coils. So here is the typical stroke series. Now, earlier I preempted this by saying, patient coming in the hospital, my passion is to give you real-life apolitical information. Yes, I love MRI, but the patient comes into the hospital, first move, CT. See if you've got an identifiable stroke. What kind of stroke? Is there blood and is there hemorrhage? Talk about that in our stroke cases. Then you'll make a decision. Do I need MRI to make a decision for thrombolysis? So here we've got MRI showing you the flare, the diffusion image down at the bottom, which shows the stroke, the ADC velocity map, low signal intensity, because low velocity, low flow. And then we can measure the mean transit time, the cerebral blood volume, the cerebral blood flow, and we'll explain those a little bit later on. We had the time to get an MRA, which shows the occlusion of the right MCA. So most of these stroke cases, if they make it to MRI, which about 50% of them do, they will get an MRA. Every stroke case that makes it to MR will get BSI, SWI, SWAN, because MRI is more sensitive with those sequences at picking up blood than CT. So if the CT shows a non-hemorrhagic stroke and the patient makes it to MRI, there's still a chance you'll find blood on the MRI. And if you do, the patient may now not be a candidate for thrombolysis. So blood-sensitive imaging is a part of the stroke series. Spectroscopy. It used to be just fun, interesting, engaging, new. But now there are some real applications for spectroscopy. You're going to learn throughout the next few days where we might use spectroscopy in unique settings. Like, for instance, we've got an extraaxial mass, and it looks and smells like a meningioma, but it has a lot of atypicality to it. And if we see an alanine peak, it's a meningioma. And we'll spend some time talking about a few of those unique applications of spectroscopy where it's appropriate. In spectroscopy, we have a little mnemonic known as lying, lazy, good crooks. Let's see, I can't even read it. Collected my insurance. There we go. So lying and lazy are the lipid and lactate peaks, which you might see in ischemia, hypoxemia, cell death, and especially in glioblastoma multiforme, as a doublet rising up at 3.2 parts per million. NAA, I forgot the no, lying, lazy, no good crooks. The no represents the cell neuron. The glutamate and glutamine peaks are going to be altered in certain inflammatory disease states and unique disease processes. Creatine is a reference point. Choline represents the phospholipids and phosphodiester's in the cell membrane. Cell membrane damage, the choline peak goes up. The phosphodiester's are released. The MI, or myoinositol, is a carrier that brings energy in and out of the cell. So if you have a cell like an Alzheimer's cell in the cingulum and it is not busy, then MI just sits there. It doesn't move around. And so the MI will start to accumulate in ALZ, or Alzheimer's disease. You could make spectroscopies of all the pixels, so-called multivoxel spectroscopy, or of just one. You can make maps of tissue. For instance, you can make a map of the entire brain's choline concentration. Why might that be valuable? Because where the cell membranes are breaking down, that's where you want to put the biopsy. Or you might use that as a technique to monitor the efficacy of a treatment. This is just a quick spectroscopy demonstration. I'm going to skip over both of these slides and go right to contrast-enhanced MRI. And we said that contrast-enhanced MRI could be performed dynamically, but it can also be performed as you know it in the equilibrium phase, looking for blood-brain barrier breakdown. When you assess that contrast enhancement, you're going to be looking at how intense it is, the shape of it. For instance, let's say we have an abscess. It's very thin. It's almost uniform, but it's a little thinner on the non-peel surface. It has a somewhat characteristic appearance as opposed to the lumpy, bumpy appearance of a GBM, as opposed to the lumpy, bumpy appearance in the meninges of, say, sarcoidosis, as opposed to the thin, delicate appearance in the meninges in somebody with a viral encephalitis. So not only are we going to look at the intensity and the distribution, but we're going to look at the character of the equilibrium phase enhancement. There are some motion reduction techniques for people that are moving around that allow us to get an MRI. They have various cute names like radar and propeller and blade and radial. Here's a demented patient. This is before we apply it. This is after we apply it. And so for gross inspection of masses and other disease processes, these can be very effective techniques. Here's a mainstream technique. It's called isotropic T2 spin echo imaging. What does isotropic mean? It means that it's equal on all sides and very, very thin. and 3D, and often overlapped, which means that you can take it and reconstruct it in any plane you want. It can be used in various parts of the body. Unfortunately, the vendors give it different names. If they use it in the head, they call it one thing. If they use it in the liver, they call it another thing. Why did they do that? That's called marketing. But it's basically the same thing. So you hear names like cube and space and vista and lava. They all pretty much mean the same thing. But isotropism is important because when you take a voxel that is completely equal on all sides and you reconstruct it, it's still beautiful. So a sagittal acquisition is still beautiful in the axial acquisition. Here is a sagittal acquisition using isotropic T2 spin echo. These are reconstructed obliques to look at the foramina. These are reconstructed axials. For a disc, this is probably all you need to do. 6 minutes, and you're done. This is one we've already covered. We're going to spend some more time on it in the orthopedic section, but since spine is part of neuro, here is where you're going to use the additive gradient echo, in the spine, where you can get 0.8, 0.5 millimeter axial slices to characterize a small disc. And again, the names for this powerful, water-weighted, three-dimensional or two-dimensional additive gradient echo sequence are ADAGE, MERGE, MEDIC, and MFFE. Here's a sagittal isotropic T2 and an axial ADAGE sequence. So you're adding a gradient echo and a spin echo to make your spine series. Another sequence you'll need to familiarize yourself with if you're going to do any spine imaging is the fat-water separation sequence, also known as FATSEP, Dixon, M-Dixon, and IDEAL. Now, a kissing cousin of this is the in-phase and out-of-phase gradient echo imaging that some of you might use for adrenal glands. So you might get an image where the spins are together, in phase, fat and water together. You measure it, gives a signal. Then you might do another sequence with a different echo time, and fat and water are out of phase, and you stop action, and you measure it. Fat's over here, water's over here. They cancel each other out. That's called OOP out-of-phase imaging. So what if you had an in-phase image and an out-of-phase image, and you add them together? Fat plus water, fat minus water. What do you get? Double fat. Write it down. You'll see double fat. What if you subtract them? Double water. So now you have 4 images from your FATSEP Dixon method, M-Dixon method ideal sequence. You have in phase, out of phase, double fat, double water. That's cool. And you're going to pick up some very interesting, subtle marrow abnormalities. And here we have them. Water, fat, in phase, out of phase. Okay, let's turn our attention now to anatomy. That went a little longer than I had hoped, but we had to start somewhere.